Eric, you've been your personal story and your professional story is just such an inspiration to so many people and to all of us here. And thank you so much for sharing it. I wanted to sort of tie together a couple things that I think we talked about yesterday with your talk, which is I think that there's two major movements going on that we should be cognizant of. I think one is how can we, in this short period of time, in the next few years, the next decade, can we impact the issues that Doug Holtz-Eakin brought before us in the Medicare program and the federal programs, and what are this small proportion of people that are suffering a lot and costing a lot? Can we use the evidence that Tom Eads programs and others have shown us to use home-based models to improve outcomes? And I think that we shouldn't lose sight that we do have some low-hanging fruit in bringing care home in the short run without having to necessarily totally conceptually change the whole health system. There's a lot of ways to make an impact in the short run in terms of reducing suffering and reducing unnecessary spending. And at the same time, I think we should be aware of the movement that you speak of care everywhere and sort of rational design. And I just wanted to, just as a comment, sort of put those two things beside one another, because I think it's, on one hand, very important to look at this holistic and anywhere future for care. At the same time, I think we have to be really focused that we have a lot of ways we can make a difference right here, right now, with some of the home care models that we have before us. And that's just one of the thoughts I had in listening to you.
So one of the reasons I've done a lot of work with home care and aging, started all the work with ASA all those years ago, with Gail and others, was because I believe that the way in which long-term care providers see the holistic needs of older people and have to care for the whole life of them, and the way that home care physicians have to deal. I mean, the disruptive part of home care is even if you're going in with a medical view, you have to deal with cats and dogs and abuse and all the kinds of things that you actually see, right? So I've always believed that home care and long-term care were going to be the sort of, strangely enough, while they're the backwards niche to sort of mainframe healthcare and often not taken seriously, were the ones who would actually understand what needs to happen in the new care model. I teach a course at Intel on leadership, and one of the principles I teach is the balance. Good leaders, great leaders balance between practical thinking and possibility thinking, and you have to be able to do both. And I think you're absolutely right. You've got to do possibility thinking to sort of set the hook about where you're going so that you know your system design is ultimately aiming for something. But you've got to do these very near-term practical things, right? I mean, I do think home care and the home care capabilities that the industry has could be one of the disruptive things that makes the rest of healthcare sort of wake up to the fact that holistic care, whole person care is needed, especially for older people, but also for people of all ages. So I appreciate the comment. I agree with it.
Hi, Erin Churiaga, NIH. Thank you so much for your talk. And the work you've done in the past has really inspired a lot of people that you're probably not aware of.
But well, it is good to know, because it doesn't feel like we're going fast enough.
What I wanted to share with you or suggest is you probably are aware of the Village movement, and their meeting has been actually simultaneous with this meeting, and they're on the Hill today. I don't know what they're doing on the Hill. But so in D.C. alone, they have 14 villages, and Mayor Gray was the keynote speaker, and they are developing wellness centers within the city, and at every wellness center, they're going to attach a village. So, and they're doing it based on the WHO age-friendly city model. So it'd be great, I would suggest, if Intel connected with them. But they really did talk about the need more for city and state government versus national or federal government, because that's where they're going to get the help.
Yeah.
But the model sounds very similar to what you described for Japan, and I didn't know if you thought, or it might work here. They're about 30,000 strong right now.
It's certainly aware of the village model, and I certainly think that's sort of some of the places where you can actually do the sort of true experiment. What I mean by the true experiment is where you can innovate the care model, innovate the payment model, and innovate the technology, and try them all long enough to where it becomes natural for the people that are in it. I mean, part of the problem is we almost nowhere in the world see the true experiment, right? We see people test a piece of technology or a piece of care model or a piece of payment reform, but they don't bring them all together. And even if they do, they'll test it for 3 months with a workforce that's told to continue to do the old job while trying out the new thing. It's not an honest experiment, right? I mean, we aren't we can't create the natural playgrounds where we can actually sort of bring all of the elements together in a sustained enough way. I used to love the sort of telehealth design of pilots and things where I left a slide out, but there's a bunch more slides that sort of give you for the website, but I put in there, why have these pilots not scaled? And one of the reasons is the design of the pilots, right? They're not designed to scale, and if you want to scale from a small pilot, you have to develop a scale design, and they aren't stacking up all of the elements and aligning the incentives, right? You know, and we know that that's the case, and we're trying to create playgrounds. I think the villages would be a great one to actually be able to do that.
Gail Hunt from the National Alliance for Caregiving.
Another one of my professors, so I'm always scared here. Right?
That's right. Well, you did a great job,
Thank you.
Eric. However,
This is Gail. Yeah.
skill shifting. I mean, I understand exactly what you're talking about and of course, it makes sense to offer training to family caregivers and neighbors and that sort of thing. But yesterday, it became really clear in our discussion that there's a lot of push to push more and more off on the family caregiver, really whether or not they're, willing to do it or able to do it. And so I just would caution you that in skill shifting, that we're sure to do an assessment of what the caregiver wants to do, and maybe even move beyond the initial primary caregiver to see if there's other people in the family who would also be able to help.
Yeah, absolutely agree. In fact, it's part of the model. I mean, this is one of those language things where it's like, I never know quite what words to use. It's like, well, the family caregiver, some of them are neighbor caregivers, and some of them are sort of community health workers with various levels. I'll tell you an example of one of the ones that we're exploring in China, and it's whether it's a family member that gets trained to do it or a community health worker or a neighbor. We don't know, right? Because you do an assessment to see whether they can and are willing, and then there's some actually incentives for them to do it. But I was talking about this with Tom last night. I'm like, we train them a little bit in IT, we train them a little bit in home repair, a little bit in social work, and a little bit in the basics of some clinical care around the classic chronic diseases, right? It's like, I don't know what to call that person, right? But you're right. I mean, sort of laying out this is what they need to learn, assessing whether they can, whether they're burdened or not, and whether they've got the intellectual and sort of basic skills to be able to do that. That's part of it, and that's part of why we're saying, look, you've got to have a quality system that's tracking that quality of care and not decimating the very people who are there. In China, at least, we're going to be able to create some incentives for those folks. When we actually get that in the United States, you and I may be gone from this earth, unfortunately, at the pace that's going sometimes.
I think we call them mom.
Yeah, we do. Yeah. And we wipe them out very quickly.
Thank you, Tom. Eric, my name is Amy Berman. I'm a senior program officer with the John A. Hartford Foundation, longtime funder of work that is represented in this room and work that you've alluded to. And I'm the one responsible for our investments in models of care around transitions, home hospital, and so on and so forth, PACE, all the things that you've talked about. You're a visionary, and you're person-centered to the core, and the combination of those two things and the fact that you get that this is an aging society and we're going to have to meet the demands is absolutely thrilling to me and to so many in the room. What I wonder is, when we think about the structure and the processes, the infrastructure to be able to support good quality care at home in a way that the person wants the care to be delivered, supports the family, I'm concerned, and I agree we're not building it out nearly fast enough, but when we think about basic things like medication reconciliation, the standards today could potentially still kill an older adult. We don't necessarily bring in geriatric expertise to think through the kinds of things that we're building at the core of a lot of this infrastructure. I'm just wondering what your thoughts are on all of that. We certainly have a mismatch. We don't have enough physicians or nurses to care for older adults. You talked about when you went to China, the first thing you did was look at the resources.
Yep.
We don't have nearly enough expertise, specific expertise, but we could be building in decision support and a whole lot of other aspects into the way in which we develop out this ideal laboratory, which I'm hoping becomes the way. So any thoughts on all of this?
Yeah, I mean, I also left out a whole nother section where I talk about the mixed discipline teams that we've had to put in place to start to sort of spec some of these things out, if you will. I mean, you're right. In places, there's just no standards, and you've got to bring experts together to at least sort of put the best practices in place that you're going to sort of try out. One of the things that healthcare is not good at in almost anywhere in the world is having a formal and iterative innovation process. And it's a whole section I wanted to talk about where I talk about our own innovation process at Intel and how we've taught this to healthcare entities. Because this is about sort of multidisciplinary teams generating requirements, going through a process that says what's known and what's not known, what can we just beg, borrow, and steal and use because it's well understood, and where do we need to focus our innovation. So one of the things I observe in the kinds of pilots of these kinds of things is people focusing on the wrong problems because they don't even have an innovation framework that helps them to know how to do innovation. They don't know how to learn from the innovation that others have already done, and they don't have an iterative mindset that says we don't have to get it all right in the beginning. There's a baseline of safety and security that you have to sort of fold into the system. So you choose your battles and you choose what you're going to sort of focus on. But I feel like one of the disruptive things that could happen in healthcare is bringing innovation processes to healthcare that all these other industries know how to do. And some of that is mixed discipline requirements, validation, all of these kinds of things. I keep talking about the moral equivalent of a product's requirement document for a care model, right? A care model requirements document, right? That's what we did with China when we sort of sat down and did this. And we didn't start with all problems. We developed a roadmap of about 30 and then said, okay, we only have the resources to start with one. Do that one, iterate. Eventually get the resources to do two. And we just don't see that kind of methodological, rigorous approach to innovation with mixed discipline teams that's kind of key to this. And we had to bring a lot of the experts in from outside of China for their particular need, given the extremity of it. But yeah, you're spot on.
Our last,
Alice is saying, Eric, you have to go to a meeting. You have to go. So sorry, got to go and visit the Hill. So thanks very much for your time. Sorry to run so late. So.